So I'll introduce the team. With me, Dr. Rami Jouaba and Dr. Anna Turian, the best team you can have, and Elias Khilo outside. And also with me, Dr. Pradeep Vyas from India. So please, Anna, maybe you would like to present the case.
Our patient is 55-year-old male with a background.
Are we able to go to the next slide, guys?
It's okay. It's okay.
Okay,
Can you describe the patient? Yes.
I will describe the patient. As our patient is 55-year-old male with a background of COPD and smoking and lung cancer with brain metastasis after radiation. He's suffering from epilepsy as well. He presented with shortness of breath with NIHA 3. His lab test showed normal renal function, hemoglobin of 13. He has severe aortic stenosis and moderate LV dysfunction, severe aortic stenosis with area of 0.6 and huge gradient of maximal gradient 100 and the mean gradient 52 millimeter with moderate aortic regurgitation and moderate PHT. Next slide, please. With the diffuse ST changes on ECG, with the borderline PR interval, no other conduction abnormalities. Next slide, please. His CT analysis showed classical bicuspid aortic valve of Sievers type 1 with raphe between right and left leaflets, as you can see from this slide. Annular size is perimeter of 84 millimeter. Raphe not severely calcified with lace of 8 millimeters. He has severe peripheral vascular disease with total occlusion of left iliac artery and the calcified plaque on his right side. Next, please. Non-obstructive coronary artery disease, as you can see from his coronary angiogram. Next slide. So our plan is to perform TAVI from right femoral artery and to place pigtail from the right radial artery. We're going to use over-the-wire pacing to perform predilatation with 20 millimeter balloon. And we will discuss about implantation of Evolute Pro Plus 29 millimeter.
So maybe before we go ahead and show you what we did until we went live, let's talk about the issue of sizing here. And Chaim, we saw your lecture. It was an excellent lecture of bicuspids and how we approach bicuspid. So here we have a perimeter of 84.5 with a conventional bicuspid, type 1, with the raphe between left and the right. But we do not expect the valve to need to be with a lot of oversizing. In fact, we do not imagine that there will be enough room to fit a 34 valve. And therefore, our thought was to go with a 29 valve. What do you think, guys?
Danny, I think it's a great point of discussion. I have some comments. Looking at the phenotype of this bicuspid valve, the raphe is barely calcified. There's very little calcium on it, right? So basically what I have been doing, when I have a situation like this, that I don't see much calcium in the raphe, these valves, they behave very much like a tricuspid valve. So personally, in this case, I would probably go with a 34 rather than a 29 because of that. If this raphe had the more calcium on it, then I would definitely consider a 29 because there's going to be very little expansion toward that area. But in this case, particularly, I would pick a 34 valve. I don't know what the others would do.
I would actually do the same. I am a strong supporter of undersizing and regarding the supraannular measurements. But here, indeed, there is not that much calcium. It's Sievers 1, but without a calcified raphe, and therefore I would actually treat this based on the annular measurements. Another option is indeed to do balloon sizing and see whether, but then you'd use a bigger balloon and see whether you'll have sealing with a 24 or 25 balloon before making a decision on undersizing.
So maybe before we get to the live point, Rami, you'll show us what we did until now.
Yeah, so we can see the angio, and we start the case with the ultrasound-guided micropuncture of the femoral artery. And after that, okay, this is the micropuncture, and we usually use it with the micropuncture and ultrasound guidance. We have the sheath inside, and we have the good entry point. After that, we advanced the sheath, which is 14 French.
So he's a guy with occlusion of the left common iliac, right? And a lot of calcification in the leg, which made us also thinking that maybe a smaller valve than a 34 would be better here, but that's another argument.
Yeah, actually, we have a small mass of the iliac artery. There's some stenosis, and you can appreciate the calcification in the iliac artery. And we know the sizing of the sheath sometimes actually different between the 29 and the 34. And while we need here 14 French, which is 5 millimeter, the need for 16 French by the 34 and to go up for 5.5 millimeter in the iliac artery. So after that, we have the pigtail. We have 2 pigtails, and one in the non-coronary cusp and the other in the common coronary with a fusion of the left and right cusp. And we have this injection. And we can see the aortic incompetence, which is mild to moderate aortic incompetence, and the alignment of the valve.
Sure. I can tell you why we already checked the 29 valve in this case under fluoro to see that it looks good. I thought a lot about whether it should be a 29 or 34, and to be honest, I'm not entirely sure whether it should be a 29 and not a 34, and the opposite. There are good arguments for both options. The leg a bit pushed us to utilize the smaller valve in this case, and also the fact that he has moderate AR to begin with also suggests to me that he may handle PVL better than a patient without baseline AR. So
can we just ask you for clarification whether the valve, the disease valve, was tubular, or was it flared, or was it tapering in any manner in terms of measurements?
Yes, we don't see it here on the screen, but when we look at it a bit above, the annulus is closer to 80 than the conventional was 84.5, and below it was 80.5, something like that. So it was smaller a bit. So it also pushed us to do it with a smaller option between the two. So maybe we'll
Danny,
go ahead. Yes,
can you-
please, Chaim.
First of all, we see that you're using a Lambda-Quist. So is this your routine wire, or you using this only in this case? And can you please elaborate a little bit more? You're getting ready to pacing through the wire. So please take us through the steps slowly, one by one.
So over the wire pacing, LV pacing, is a method that can reduce the potential risks of having a RV pacemaker, and maybe less one axis that you can maybe use in these type of cases. So we are connected in one port, you can see it on the table, to a wire that is going through one of the sheaths, and the second one is connected to the back of the Landerquist after we have shaved it. And we may even test it right now in front of you guys. We'll check that the pacing works well. Let's
100.
do 100 with the maximal output. Async.
Okay. So we see there's a good capture, yeah, and it's working. Thank you.
Okay, you can stop.
Yeah.
So it's making the procedure a bit more minimalist. Obviously, the challenges with over-the-wire pacing is in cases that will
100,
suddenly become
180.
pacemaker dependent,
With maximum.
then we cannot just pull the wire out of the LV. Then we will need to put a pacemaker conventionally through the vein and maybe to do a permanent pacemaker later on. So now we have a 22 valve coming in, a balloon, sorry. We'll go to the cusp overlap view.
You don't mind us interrupting you for the purposes of the audience and
Oh,
the
please,
messaging to
please.
the audience?
That's the most important thing for today. Yes, please. Let's-
Lunderquist, is that your wire of choice for
Lunderquist
bicuspid
is,
or for all cases?
So maybe since
So we were
the
doing
balloon
the
is inside,
balloon.
I will do the balloon and then we talk about
We'll
the
do
Lunderquist.
pacing, please. 180.
Okay,
Yeah,
I'm going slowly. Okay.
yeah, okay.
Okay.
Down,
Down, off pacing.
off pacing.
So Lunderquist is my wire of choice in evolute cases. It's not it was not my common wire historically. I was using more Confida wire. That was the wire that was tested by Medtronic and Steve Brecker 5-10 years ago. But later on I understood and that the Lunderquist enables me to get more support and high implantations in evolute procedures. And since then, I use routinely the double curve Lunderquist wire in these cases.
You know, there was shift towards Lunderquist or emphasis on Lunderquist for cuspal overlay technique. Is
Correct.
that one of the reasons? And I will ask Hui and
Let's do RAO.
are you a proponent of the Lunderquist for cuspal overlaps in every case?
Yeah, but I'm not using it in every case. Still, if the anatomy is very straightforward, I think we can manage with a Confida as well. Currently, it's about 50-50. But whenever there is certain amount of horizontality or tortuosity of the iliacs, then definitely Lunderquist will be the choice.
Yeah, I agree. I used to use more Lunderquist with the Evolut Pro Plus, and this is shifting back to the Safari or Confida with FX. But I think the best wire is the one they're more comfortable with, honestly. So I don't like strongly recommend one wire or the other. I just feel comfortable, whatever you feel more comfortable with.
I think in certain anatomies, particularly if you have a horizontal aorta and a very calcified anatomy, these heavy wires should be chosen. Otherwise, the risk of ventricular laceration would be there with these heavier wires like Lunderquist. So routinely, we should probably take the Safari or the Confida and keep Lunderquist for difficult anatomies.
Yeah, including right and non-coronary cusp fusion and bicuspids.
Where the trajectory is
Trajectory is totally awkward.
So in
Pay
this
attention
particular
that they're
case,
using it.
yeah, in this particular case, since we chose the smaller size device, then we want a very high position. Like a 6 millimeter depth in this type of case would be very bad. We don't want 6 millimeter, and this is another reason to have more control on the implantation. Hopefully this is what we'll get. Here we are in LAO projection, seeing the valve and the top hat in order to have commissural alignment. Looks good in this type of view. You see the top hat in the descending aorta. This is how the end of the capsule should look like. It means that we're in good shape. Okay. Yeah.
Okay, so we can advance.
We're advancing the valve.
Nothing.
So in the case today, no doubt that the Pro Plus enabled us to get an external
implantation.
skirt device. Okay, we can go to our a device with external skirt that will still have a label for 5 millimeter. We don't have it with other options. So this is a mid-pictal position for the top hat, and the top hat morphology is good for cusp overlap. So we are in RAO caudal in the view that the non was alone on the left side of the screen, and the right and the left are in the right side of the screen. They are together with the raphe between them. Maybe we'll start the first step a bit quicker, yeah? Maybe you can pace in 120, Muhammad.
Let's take a test, maybe?
Yeah, let's take a test. Yeah, okay. Sine?
Okay.
Dr. Atizani,
Okay, so we are like minus one. Yes, please, guys.
Go ahead, Vijay.
Dr. Atizani, is there a data which is saying that LV pacing is superior to RV pacing in TAVI, or is it just a fascination that we have to do LV pacing? Because we are probably, if you
-1.
are so apprehensive of RV perforation by a temporary
Let's touch on
catheter.
this later.
We will
The
discuss
team
that.
is actually doing the release now, so let's focus with the team.
Yeah, let's take a picture here, maybe, guys. Sine?
For the audience, this is
So
a
we
great
are like
demonstration
1 or 2
of a
millimeters
cusp overlap.
below. We see the non-moving alone on the left side. Hopefully it will not go deeper than what we have now.
Right?
So we'll do a
So
very
you're-
slow positioning. There is no rush. Like this is what we teach the fellows here. The valve
No
comes.
3 and 0 level.
Yeah.
And very stable pacing throughout the procedure. Nice.
It may have come up a bit. Let's do another C9 injection. No, looks stable. It's maybe -1 or 0.
Yeah.
I'll give you a bit of tension. Maybe you
I have
just
to,
a little bit.
yeah.
Okay, that's enough.
I think it's good.
So I'm doing really slow movements here and stop even. The patient is stable. There is no need to rush. Well, let's look
About
at the
4
screen.
now.
Yeah, we may correct it slightly, the projection. Now it's maybe a bit better. Let's do a stronger injection like LV. Okay, please. So I'm not entirely sure that
Looks
we're...
good.
It looks good. I'm not entirely sure, Chaim, that we're aligned perfectly to the valve with the coaxiality. Do fluoro. Let's correct it
I
a
guess
bit.
you cannot check it now, but rather go up to the 80% and then go LAO.
Yeah.
Slowly get to the point.
Gentle forward tension. Let's do 140. I see that it's jumping. 140. We really like the Evolute valve. You saw that it's very, very stable. Okay. Let's stop pacing and see what we get.
Yeah.
Okay.
Totally stable. Yeah.
This is him. Okay, fluoro.
Okay.
We'll correct the projection slightly. Think that we are in a very good position. Let's take a picture here, please. Guys, it's not leaking and it's 1 millimeter, maybe around 1 to 2 millimeters. This is what we wanted.
Looks very good at this point.
Yeah.
That's a beautiful
Do you go
position.
LAO now?
Yeah, let's do LAO. It's interesting, Chaim, how this is how Jean-Claude taught us how to do TAVI, and you taught us. You are like one of the most famous proctors, right, Chaim, of Evolute. It was always LAO, and now we are implanting in.
And now we're
our-
playing
Decode them
between
all?
different projection,
Yes.
adding information in each one.
Yes,
Yeah.
yes, please.
Okay. Yeah, ready?
Sine?
Ready.
Beautiful,
It seems
beautiful. Okay,
good. Okay.
let's now
The wire.
pull the wire slightly. Let's see how, if the, like you said, guys, whether it will still enable us to pace. I will not pull it completely, but something like that. The Katsev 120, we will pace 120. Let's see if it's still effective. It's still effective. I'll pull it a bit even more.
I think to leave the pigtail.
Okay, it's still pacing, although I pulled. No, let's
No,
keep the pic.
that's why.
Okay.
Okay. So it's
So again, very, very slow movements, gentle forward tension.
See how slowly they go and how stable the system is.
There is no real need to rush. Sometimes, unfortunately, we do rush in these cases, but because of patients being unstable or something. But if they are not unstable, there is no need to rush. We let the system naturally open.
I think this is a key point of the procedure, really going very slow there, enabling the nitinol to expand and hold the valve in place. I think it's perfect.
I have another question for all of you, including yourself, Danny. I have a tendency to let the valve sit there for a period of 4 to 5 minutes for the nitinol to expand and the valve to get stable prior to release.
Pressing off.
Seems a good idea,
Pressing
and
off.
that's the time it would take for it to stabilize well
In
and
the
expand well.
70%, like in what step? Like
Do
when
you
it's
practice that at all? Never?
usually no, but I can understand the logic behind it.
This is actually a good point, Dr. Seth, that some people mentioned to me this. I was actually having this conversation with the engineers at Medtronic, right? If the valve is still connected to the catheter, you can leave there as long as it's not going to expand beyond a certain point because it's prevented by that connection, right? So I think what we do all the time is going very, very slowly in the final deployment to give some time for the nitinol to expand. We do pretty much very similar to what Danny did here in a very, very slow final deployment to enable the nitinol to progressively expand. What we do differently, we pull the wire, the whole thing. We don't leave any wire behind because we don't pace over the wire, right?
Yeah, I've seen that. I've seen your delivery.
And we don't pace at the time of release.
We do.
I do pace 100%, all of the cases.
He wasn't pacing.
He was pacing. He was pacing at a
At a slow rate.
120.
At a low rate.
Yeah. So the diastolic blood pressure is 90, which makes us all happy here. And we are bringing the sheath back.
So Danny, just a comment here. How
yes, please.
your patient is awake, I'm assuming, right? It's a minimalist
absolutely.
TAVI. So how are you going to assess now? What's your next step? You're going to do transthoracic echo and hemodynamics to assess the results. Do you combine those results in terms of the understanding of whether or not to have PVL, if the LVDP is stable or went high? What do you do? What is your final assessment of the valve?
It's also a very important, great question. And so gradients, we rarely have gradients in conventional TAVI, non-valve in valve cases. And we can check gradients in the room also. AR, in almost all of the situations, we understand AR by the hemodynamics and by aortograms. The only added thing that is clearly echo thing is pericardial effusion. Except for pericardial effusion, to be honest, and situations like borderline situations, whether to post-dilate or not to post-dilate, if you're not sure from the hemodynamics or aortogram, I don't see anymore the benefit of having echo like routinely in these cases, like during the case. But so more and more we do not really utilize them.
Okay. So this is double back, Maria. Okay.
Very impressive, and it appears, Danny, that you were right.
Yeah.
That the 29 indeed provided us with excellent sealing and excellent hemodynamics.
Let's do an injection. Maybe we'll show you an injection and then you can go to Toulouse and see their interesting case. So, just a second. That. Maybe a bit lower with the pictal, just slightly.
Yeah, it seems okay.
Okay, that's good. No, it's good. Okay.
Yeah.
Sine?
Okay.
Yeah, it went deeper than we expected just at the end, I think, but no leakage whatsoever. And Looks good. Even
Seems good. Even the ECG, there's no changes, and PR and QRS are same as. And
It's
think
an
that was a-
excellent result, yeah. No, the hemodynamics are wonderful. There is no leak, coronaries do flow, so it appears that this was the right decision. Indeed, it appears that it did kind of sink down or dive down in like 2 millimeters, but
we can
doesn't
do
really
another
affect
picture
the
in RO
hemodynamics.
caudal just for our interest. Just a second. So this is the view that we have the unexpanded raphe on the right side of the screen. Just a second, something like that.
okay.
Okay, please. It's maybe a bit higher in this view. You see that the bottom of the non is not so higher above than what we think. It's well, and there is no AR whatsoever, so we're happy.
Danny, that was a great case. I think it was very educational to everyone here. Your team did a phenomenal job. Thank you very much, and we're looking
See you
forward to our
soon.
next case. Thank you.
Thank you.
That was
See you
tremendous.
soon.
Congratulations, great result.